Next, now you see what happens is, once the patient comes to you with the anterior dislocation of the shoulder, you have diagnosed it, clinically diagnosed it, and you have made the diagnosis based on the x-rays also, and then you went for the reduction. You have reduced it successfully. Then what you do, you will immobilize it. You will hold the arm in elbow pouch or the arm pouch and ask a patient, if the patient is young, ask a patient not to abduct the shoulder, not to externally rotate the shoulder for the possible duration of 1 to 1.5 months. Alright, you will ask a patient voluntarily to restrict abduction and external rotation. But you know, majority of the works or majority of the occupational works which are achieved by the hand is through the function of abduction and external rotation. And the patient cannot wait for the period of, will not wait, despite the advice given, he might not wait for the period of 1 to 1.5 months of restriction of abduction and external rotation, because he will think that I'm all fine. All right. But what happens is that the anterior envelope, it fails to heal completely. The anterior envelope of the muscle, it fails to heal completely, thereby giving a possibility of recurrent dislocations easier than the previous one. All right. This will lead to a condition known as recurrent dislocation of the shoulder. So what is there in recurrent dislocation of the shoulder, or what happens in case of recurrent dislocation of the shoulder? Recurrent means again and again. For the first time, there was a trauma which led to this anterior dislocation. But subsequently, because of the anterior weak structures, the recurrent dislocation happens with a much lesser force. And it will be converted into a habitual dislocation, all right, where the patient will be in a habit of getting it dislocated and relocated. So, what are the two basic lesions which are found to be associated with this recurrent anterior dislocation of the shoulder? One is Bankart lesion, other one is Hill-Sachs lesion. Now, if you look at this Bankart lesion, what it is, in the glenoid labrum, the anterior slit is there. That means there is an anterior split which is leading the way for this anterior dislocation to happen. So, what is Bankart lesion? It is the lesion in anterior rim of glenoid labrum. All right. It is a lesion in the anterior rim of the glenoid labrum. And this is how it can be visualized on the x-rays also. Now, Bankart lesion can be soft tissue Bankart lesion or a bony Bankart lesion also. Bony means where the lesion extend to involve the bony glenoid region also. All right. So, this is how the glenoid labrum associated injuries. This is one such lesion which is responsible for as well as becomes a lesion for a recurrent anterior dislocation of the shoulder. Second is the Hill-Sachs lesion. Now, just try to understand. Every time there is an anterior dislocation, it is the posterolateral surface of the head of the humerus which will come in front of the glenoid bone. And it will receive a hit from the anterior rim of the glenoid. For the first time, second, third, fourth, 10th, 15th time, if the same thing is happening on the same region, then it will create a depression. It will create an impression on the posterolateral surface head of the humerus. And that depression is known as Hill-Sachs lesion. So, what is Hill-Sachs lesion? It is the depression on, posterolateral surface head of humerus. All right. So, what the examiner clinically or what the examiner specifically is asking for you is this one, because he can give you 4 confusing options like anteromedial, anterolateral, posteromedial, posterolateral. So, these are the confusing options that the examiner can give you, and he is specifically asking for where exactly this lesion happens. Now, if you can very clearly locate this lesion, that here there is a depression, although it is seen laterally on the x-rays, but actually it is posterolateral. And you know the reason why it is there on the posterolateral surface head of the humerus. Alright. So, that is Hill-Sachs lesion. So, as far as recurrent dislocation of the shoulder is concerned, these are the 2 lesions that you have to remember. So, this much all about anterior dislocation. So, what we have talked about anterior dislocation is 1, the types. Second, the clinical features. 100% of your questions are going to be asked from clinical features. Third one is the management. Alright. And the fourth one is the complication, that is recurrent anterior dislocation. Next type is the posterior dislocation of the shoulder. Obviously, it is less common in comparison to what we have seen, that is anterior was more common. Posterior dislocation of the shoulder is a less common variety. But you know, every time you get a question in your examination, there will always be a hint provided to you in the form of an etiology, and that is a history of electric shock, the history of convulsions. All right, that means the history of fits. It could be a history of convulsion or history of electric shock. Now, what is the reason? Imagine a patient is sustaining an electric shock. There will be a shoulder which will be thrusted posteriorly, and that posterior thrust will result in posterior dislocation of the shoulder, where the patient will vent unconscious. All right. So what is the attitude because of this posterior dislocation? How the patient will be presenting to you? It is, when it is posteriorly dislocated, there is no medial migration of the head of the humerus. Because of a spine of scapula, it remains lateral. So the medial musculature will be contracting, leading to adduction of the arm. When it is posteriorly dislocated, the anterior musculature will be more contracting, followed by stretching. So there will be internal rotation of the arm. All right. So it is adduction and internal rotation. Adduction and internal rotation are the key observatory findings in the attitude of posterior dislocation of the shoulder. Third one is flexion, because the patient again would be having some pain. Once he regains consciousness, the patient finds it to be painful. So he will hold it with the flexion, means he will hold the arm by using the elbow, and it will be kept in flexion. That means in front of the body. All right. So flexion, it is attributed to, or this is the contributory reason for the flexion. So flexion, adduction, internal rotation. And what we have witnessed in anterior dislocation of the shoulder was flexion, abduction and external rotation. So that is the difference the examiner wants from you that you should be aware of. All right. As far as x-rays are concerned, if you look at the x-ray, there are two clinical x-ray findings or characteristic x-ray finding. One is empty glenoid. Empty glenoid means the glenoid seems to be not articulating with the head of the humerus, as if it is empty. All right. The head of the humerus is not congruently getting articulated with it. And second is light bulb sign, because instead of this shape of the humerus, this anterior shape of the humerus, the anterior shape of the humerus becomes like this. All right. When you see it on the x-ray AP view, then the shape of the humerus becomes like a light bulb. That is the reason why it is called by the name of electric bulb sign or a empty glenoid sign. Now, as far as recurrent posterior dislocation is concerned, here the lesion is going to be there on the anterior surface of the humerus. So anteromedial surface of the humerus. There it was posterolateral surface of the humerus. So what is reverse hill sac lesion? It is the depression on anteromedial surface head of the humerus, which is clearly opposite to what we have seen in hill sac lesion because of recurrent anterior dislocations. All right. So this is the lesion of recurrent posterior dislocation of the shoulder. This is again something that you should be aware of. And then finally is the inferior dislocation of the shoulder. Now this is the least common variety. It is extremely less common for a shoulder to get dislocated inferiorly. It is known by the name of luxatio erecta, because every time the patient comes to you in the emergency, he will be holding the arm in beyond 90 degree of abduction like this. All right. Beyond 90 degree of abduction, he will be holding the arm, and that is the reason why it is known by the name of luxatio erecta, where it is erected. All right. So what is the attitude? It is overhead abduction of the arm or hyper abduction of the arm, and it is also known by the name of luxatio erecta. These are the two findings only that you have to remember in inferior dislocation of the shoulder. So with this we have concluded, or with this we have covered the topic of very important topic of shoulder dislocation. Hope you will be able to find it helpful in marking the correct answer related to the topic. What we have already talked about were the two questions or three questions, sample questions in the beginning. Now is the time to have an answer of those sample questions. Now 27-year-old sustained injury to the right shoulder. So, examiner is asking about a shoulder injury. Falling from electric pole due to electric shock. Now, although this is a finding which you know go in relation with the posterior dislocation of the shoulder, but till now, you have not concluded the diagnosis. Possibility is there that the answer will be posterior dislocation, but the conclusion will be based on the attitude. Then, following which his arm was fixed in adduction and internal rotation, and this confirms your finding. That means the arm is held in adduction and internal rotation. What is the most probable diagnosis the patient is suffering from? Answer is posterior dislocation of the shoulder joint. Alright, and as I told you, the etiology in the form of a hint will always be provided regarding this posterior dislocation of the shoulder questions. Next, which of the following is incorrect for anterior dislocation of the shoulder? Flexion or abduction? This is correct. Abduction, external rotation is also correct, because you know flexion, abduction and external rotation is the attitude for anterior dislocation. Adduction, internal rotation is incorrect. Flexion and abduction is correct. So what is the answer for this question? It is C, that is adduction and external rotation, because it is abduction and external rotation which is the correct answer for this particular question. Next question, next again sample question is that which of the following lesion on the head of the humerus results, means in recurrent dislocation of the shoulder, recurrent anterior dislocation of the shoulder, what will happen to the, or where in the humerus the depression will happen? Answer for that question is posterolateral. You already are aware, there is no need to mingle, there is no need to struggle among the options. All right, the answer for that question is posterolateral. So hopefully you will be able to solve every question asked in relation to this very important topic, that is dislocation of the shoulder joint.